Good afternoon. Hello. Welcome to today's webinar. My name's Sam Campbell. I know very many of you out there. I'm a research director for emergency medicine in Halifax. I am originally from South Africa, trained in Vancouver, and I've been in Halifax for the last 23 or 24 years. I'm really pleased to be able to moderate this webinar this afternoon and very excited. We have a couple of fantastic speakers. The webinar topic was independently conceived by the Scientific Planning Committee, led by Dr. Edin Lang, Stacey Kitts, Kirat Greenwald, and Peter Ericlesius, none of whom have any conflicts of interest to declare. I don't have any conflicts myself. The presentation was made possible by an educational grant from GSK and Pfizer, who we'd like to thank for our generosity. So all efforts were made to mitigate any potential bias. I'll just let you guys read that. I'm not going to go through it all. Just to give you a bit of background on the webinar's development, it's the first in a two-part series following a needs assessment in November of last year. Topics on COVID were selected. Today's webinar covers predictions and the current state of COVID in the emergency department for this winter. And the second webinar, which will be in 2 weeks' time, will cover COVID treatment. These are the learning objectives. Just to increase the interactivity of the session, we encourage you to use the chat feature to submit your questions. We'll try and address as many of those as we can. We're going to hold questions till the end so that both speakers can contribute their opinions as fits the particular question. So if you don't mind, I'll just like to introduce our first speaker. Alim Pardhan is graduated from University of Manitoba, completed his residency at McMaster. He subsequently completed an MBA at the Richard Ivey School of Business, and he's currently a staff emerge doc at the Hamilton Health Science Centre in McMaster's Children's Hospital. He's the program director of the Royal College program in McMaster, and is the physician site lead for the Hamilton General Hospital Emergency Department. His interests are inclusive of medical education, physician leadership, and hospital administration. Alim, thank you so much for agreeing to speak with us today.
Thank you very much, Sam, and thank you for the kind introduction as well as the invitation. So I'm going to be speaking about a couple of things. So one is going to be predictions of the impact of COVID-19 and the current state of the emergency department. And then I'll be talking a little bit about the COVID-19 related challenges impacting the emergency department. And so I think a lot of this data is going to be stuff that people have already seen or heard of, but I think it's worth sort of going through sort of more formally. So I'm happy to do that. So one of the challenges, of course, is that looking at COVID-19 in isolation is likely insufficient, given the current state of emergency departments nationally. Part of the challenge is that both testing and reporting has fallen off, as many provinces have stopped doing that on a regular basis due to political decision making. And so we have limited data of the general population. And when looking at national level data, we have some hospital level data, but a lot of that is about a month or so old. So just in terms of some of my disclosures, so I have no specific conflicts to identify. I do receive a number of stipends for some of the administrative roles that I hold, and I have no patents for drugs or devices. So just looking at the COVID numbers in hospital. So again, unfortunately, the data is is about a month old. A lot of the provincial data is not necessarily being published on a regular basis, at least not information that I could find readily. So the best information I could find was actually from the Critical Care Society of Canada, which shows that our total hospitalizations for COVID are sitting in the mid 3,000s. And in terms of the ICU is sort of sitting in the mid about 150-ish or so. And that was as of about a month and a half ago. For interest's sake, the breakdown by variant is shown here. So almost all of it is now Omicron. So Kraken, which is the recombinant strain, is generally only about 2.5% of cases, and is this sort of little area down at the bottom here, although that may have increased since the last time that I was able to take a look at the data. In terms of a time series, the numbers aren't huge, but again, this is Ontario data because it was the data I was able to readily access. Almost impossible to find national cumulative data, but I think this gives a good sense of what we are seeing nationally. Of course, part of the challenges is that this number is almost certainly underreported, as most of our testing is either people doing their own rapids at home, or high-risk patients that we're seeing in the hospital, or patients that are admitted. And that is really the only groups of people that we're getting reports on in terms of COVID positive tests. So in terms of age distribution, again, all likely underreported. Not surprisingly, we're seeing sort of, a lot in this over 80 population who are likely getting admitted or getting tested because they fall into that high risk group. And the rest of the groups are relatively flat, partially because they're likely doing their own rapid testing at home, as opposed to actually doing any kind of PCR testing that we're getting general reports on. In terms of mortality and deaths, again, not particularly surprisingly, the majority of the deaths that we're seeing are in the elderly and older patients with comorbidities, and the rest of the groups are running sort of in lower numbers in terms of mortality associated with COVID. So test positivity. So this is one of the metrics that we were looking at very early in the pandemic in terms of how many tests that we're doing are coming back positive. And so although testing is relatively low, we're certainly seeing relatively high test percentages positive. And again, these are tests that are being done on high-risk patients and in hospital settings. And so our test positivity of around 15% is pretty high. And again, the data is about a month old. Of course, part of the challenges is that this is entirely not the whole story. And so, when we look at COVID in isolation is likely not giving us a good picture of the effects that it's having on the hospitals, the healthcare system, and specifically the emergency departments. So concurrently with COVID, we are also seeing flu, which has started to pop up. Certainly in Ontario, we were seeing lots of flu A that sort of swept through over about a month. And we've actually seen a couple of flu B cases now. So it's certainly here and is coming. And so this data is more up to date. But again, only part of the story. So we've got COVID, and overlaid on that is also the flu. And then overlaid on top of that, so this is again flu data, which shows sort of the number of tests completed, and then our flu A positivity rate. So flu B still is a pretty flat line up until sort of the end of December. Like I said, we have seen a couple of cases, but certainly not in the degree of spread that we have for flu A yet, although that could still be coming. And then, of course, layered on top of that is all the other viruses. So RSV was relatively easy to find in terms of data. So certainly seeing lots of RSV. And again, for those who work in children's hospitals or see children in the emergency department, we've definitely seen lots of RSV, lots of very sick bronchiolitics. Respiratory season this year was particularly busy and continues to be busy, although has leveled out a little bit. But certainly seeing lots of RSV testing and RSV positive cases as well. So all that being said, is it the perfect storm of lots of viruses all happening all at the same time when hospitals are under significant amounts of stress and burden already. So how does this affect the challenges in the emergency department? So of course, the question that all the time, do the respiratory season? RSV, we have the flu, we have rhinoentero, all of those come at this time of the year. So why is this year any different? And so the next following slides are mostly all taken from Ontario sources, but again, I think is very generalizable to the rest of the country. And if anything, I would say is generalizable internationally as well. So, certainly this is an Ontario, this is an article from Ontario. However, I would say that I have seen similar stories nationally and also internationally. So for anyone who's on Twitter and follows, any emerge physicians or paramedics or others in Australia and the UK, certainly there has been lots of chatter about very similar challenges in those jurisdictions as well. So I think all of us have seen increases in offload delays. So in Ontario, the average is 50 minutes, but the 90th percentile is a couple of hours. And I would say that all of us have got anecdotes of patients who have been on offload delay for 4, 5, 6 hours. And speaking for myself, and I know speaking for many of my colleagues and others that I've spoken to, lots of us have assessed and discharged patients right off of ambulance stretchers, mostly because we have no room in the emergency department to see them. Certainly, the other challenge is an issue of health human resources. And so, as was well articulated in a recent letter by the CAPE leadership, one of our biggest challenges is one of health human resources. So bed block is a major challenge for us. Wards can certainly close their doors when their beds are full. We do not have that luxury. Although I will say that certainly many of the centers that I've spoke where I work, or centers that I've certainly chatted with, their wards are going over census to try and help us decant the emergency department so that we can see new patients. And on top of that, the challenge that we have is that the wards and the emergency department and our critical care units are all short. So both physicians, nurses, other healthcare professionals, and there's only so far that we can push people and still keep our patients safe. So for our purposes, and as you all know, patients waiting for beds in the hospital are boarded in the emerge, which then leads to more patients on offload delay on ambulance stretchers. So certainly, again, very generalizable across the country. Why are people leaving? So in Ontario, certainly Bill 124 was a major barrier or major challenge in terms of people wanting to leave. The other thing that we've heard from those of our teams that have left is unsustainable work conditions. So on the wards, they sometimes have 1:8, 1:10 nursing ratios. In the emergency department, we are caring for patients in hallways, in closets, in the waiting room. As one of my colleagues in Kingston put it, we're trying to solve the worst jigsaw puzzle ever, and we're doing it every single day. So some of our barriers to care, which again, I know all of you are aware, is there's no inpatient beds for patients. And so some of this is that our inpatient wards are full, often they're over census. We have wards on outbreak, and while they can close the ward if they're on outbreak, the emerge can't close. They don't, and I don't blame the inpatient units either. They're also being run off their feet. They have nowhere to send patients when they're ready for discharge. And so oftentimes it's a lack of community resources that is then backing up into those wards. There are added barriers being put in place by isolation requirements, by step-down requirements, and by telemetry requirements. So, one of the challenges that I know all of us here is that it's okay for us to have 2 isolated patients separated by our magical HEPA filtering curtains down and emerge, but on the floor, we can't necessarily cohort those patients together. We have staffing shortages, so healthcare professionals of all types, a combination of people having retired, moved to jobs that are less stressful, less on fire. We have staff who are on quarantine for various reasons. We have both upstream and downstream problems. And I would say that certainly upstream, our family physician colleagues are struggling just as much as we are to try and keep up with the demand that they are facing. So one of the things that has certainly come up is that how is telemedicine factoring into, how is telemedicine being factored into, or how is it being used as a method to address barriers in care? And so certainly there are very mixed opinions about this. I think there are definitely good stories and anecdotes of where telemedicine has certainly helped and has helped, limit people coming to the emergency department, or has limited, or has enhanced the ability of family physicians and other specialists to be able to manage patients in the community without having them to come into hospital. But again, I think there are also just as many anecdotes on the opposite side where patients are not being necessarily assessed appropriately through a purely a purely telemedicine approach as opposed to a more holistic approach to care. And so I think there's certainly lots of divide in terms of is this something that has been a benefit? I think there's definitely benefits to it, but there's also some challenges and risks that have gone around with it. And we often end up seeing the worst parts of it when it comes to light. So we've certainly also seen lots of surgical backlogs. So delays as a result of COVID has led to surgery backlogs. These delays lead to urgent cases becoming emergent cases and then end up on our collective doorstep. Certainly the children's hospitals also have been struggling significantly with volume. And a lot of what that means is that their overflow, certainly in some jurisdictions like on Ontario, some of their older patients have actually been repatriated to general hospitals to manage because the pediatric centers don't have space. So certainly this is an article from one of the hospital that I work at. And so, the triple-demic hit the children's hospitals pretty hard. Our volumes were through the roof for a couple of months with significant capacity issues that I don't think we haven't seen certainly in the last 10 years, particularly in pediatric critical care. COVID has also led to increased mental health challenges and eating disorders in our pediatric populations. And so the stresses on the children's hospital led to the general hospitals having younger patients admitted there when they did not need specialized or tertiary care children's hospitals. And now they also have a backlog of surgeries. So in Hamilton, that number is around 2,500 in terms of backlog pediatric surgery. So to give a sense of where this leaves us, and before I hand it back over to Sam, is that this leads to significant overcrowding in the hospitals, which then leads to overcrowding in emerge, which leads to delays in care, longer wait times, and then ultimately poorer outcomes. As I'm sure all of you have seen, there was some recent data that suggested that there will be one additional death for every 82 patients spending an extended period of time waiting in the emerge for admission. So that's anything greater than 6 to 8 hours. And so there is certainly an association between delays to admission, so patients going to inpatient beds, and all-cause 30-day mortality. So hopefully that paints a reasonable picture of sort of where COVID is, and also some of the challenges that we're facing in terms of access to care and barriers to care in the emergency department. I'll hand it back over to Sam.
Thanks very much, Alim. That was wonderful. The next speaker we're going to have is Dr. Zain Chagla. Dr. Chagla has contributed to local, provincial, and federal policy planning and to several clinical trials on COVID-19 therapies. He's an associate prof at McMaster. He's co-director of the infection control at St. Joe's Healthcare Hamilton and infection control consultant at Woodstock General Hospital. He's a BSc and an MD from Queen's. He did a residency in emergency medicine at Western. He's an infectious disease fellowship at McMaster and a MSc in infectious diseases. He also has a diploma in tropical medicine from the London School of Tropical Medicine and Hygiene. Zain, take it away. Thank you very much for speaking to us.
To get off mute. Thanks, everyone, and thank you for having me today. So today I want to talk a little bit more practically around both testing challenges and kind of that risk stratification of patients who have COVID-19 presenting to the department. Next session in 2 weeks, we're going to talk a lot more about therapeutics, but I'm happy to answer questions if they do come up in that context. But really just kind of how to streamline that patient that shows up with COVID concerns. So these are my disclosures. None of them I think will be mentioned as part of this project. So we have really kind of 3 sets of COVID tests that are available. We have rapid antigen tests that many of you are familiar with that give you a result very quickly. We'll talk about each one. We have semi-molecular PCRs. So the ID now, which is the one that's been used the most across the country because of a federal purchase. So they're not full PCRs, but they have the advantage of much more rapid turnaround with a little bit less sensitivity. And then finally, we have our lab PCRs, which have been kind of the gold standard since the beginning, and have their benefits and risks associated with them. So, we have rapid antigen tests. These are cheap the pennies for hospital systems and healthcare systems, and they're commercially available. These have been, a really interesting success story in their distribution to the general population once they were here, in the sense of allowing people to do point of care testing at the bedside, really, outside of home pregnancy testing. There wasn't really a medical device that really was used as a diagnostic test that was really sent to patients to do themselves. We have fast turnaround, so if done correctly, you get an answer relatively quickly, even 15 minutes. And then realistically, no technical expertise. Obviously, you have to know how to do it appropriately, develop the test. And that is a problem for certain individuals who may have cognitive issues or may not speak English or may have issues interpreting the instructions of the test. But for a healthcare worker who's administering them, as long as they've done one, they're usually pretty reasonable in terms of the technique. The downside of rapid tests is in a sense, they pick up people with high levels of virus, but there are things that can lead to a negative result that is actually a positive result. The first is technique. So, again, I think as we learned, especially with Omicron, with a lot more ear, nose, and throat shedding, is that, a nasal swab compared to PCR, this was a study that was actually done in Nova Scotia, where a nasal swab had a lower sensitivity at about 68% as compared to gold standard. Whereas when adding throat and nasal, so, bilateral tonsillar pillars, then bilateral nares, and then doing the test, you increase it to 81.6%. And so, especially early in that course, particularly for that patient, if you're going to use this as a test, make sure that patients, that you're doing it appropriately. So you're going to swab both. Make sure if patients are being instructed to test, after an exposure, or you're giving out tests, in your practice, that, you instruct patients to do it correctly. You want the benefits of this test being there in terms of having a positive result. And if a technical issue is easy to overcome with a bit of education. And then, we have this issue of when tests really do test positive. And, prior to really immunologic predominance in the population where we had immunity through vaccination or prior infection, that first time when people are truly infectious and have a detectable viral load often occurred before symptom onset or right at symptom onset. So, if I'm sick today, I do a rapid test, more likely I should be able to pick up a significant amount of virus to be able to trigger a rapid test and then use that going forward. We knew people were infectious in a day or two before they had symptoms. What seems to have happened, and either with Omicron, but more with vaccination altogether, is that we are seeing systemic manifestations very early in the viral load period. And that may be from immunologic priming, from our innate and memory cells kind of knowing what to do with the virus as they see it very quickly. And so that window between getting a viral load and symptom onset is actually now starting to fall into symptom onset. So we are seeing very regularly people that have a clear COVID diagnosis that are molecularly positive, but they're rapid and are symptomatic, but the rapid test is negative, and in fact needs to be repeated for a couple of days before they start seeing that positive result. And so when you're interpreting these tests in that context, knowing where they are in their symptom onset is important. Yes, by day 5 of symptom onset, people should have a viral load that should trigger you to have a positive rapid test. But if it's day 1 of symptom onset, a high-risk patient, their rapid test is negative, you should be telling them to retest themselves. And in fact, a big US study I cite here that looked at performance of rapid tests prospectively in patients infected with COVID, and they saw optimal sensitivity and specificity characteristics of about 3 tests over 48 hours if they were asymptomatic, so kind of post-exposure, or kind of using it as a screen to go into public or into a high-risk setting. and then 2 tests over 48 hours if they were symptomatic. And I think this has now been integrated just recently, actually, into the CDC advice for using rapid testing. But, again, just making sure patients know how to interpret that test appropriately, not just using a single test to rule in or rule out the disease, especially if there are implications with a positive test. Next, we have rapid molecular tests. The one that's been available in Canada the most is the ID Now. This is, again, uses an assay called LAMP, which is kind of a shortcut of PCR, and essentially, has molecular amplification at the heart of the test, but can be done in an isothermal reaction, which means it can be done in a single unit at a bedside or at a table, and produce a relatively reliable result. And so this was actually a study that was done in Alberta at their assessment centers, validating ID Now, which is the rapid molecular test, and everyone would get an ID Now and a PCR. And in this study, they saw about a 96% correlation sensitivity in assessment centers, and 98% specificity. And then in hospital, it was a bit lower in terms of sensitivity. And that may be because as patients present to hospital with COVID-19, they're often in their late phase, and their viral loads are actually starting to go low. It's really inflammation that brings people in. And so but the sensitivity was a bit lower in that context. Specificity is still good. So, this is, if you have a positive result, I think you can trust this in an assessment center of a symptomatic patient. If you have a negative result, similarly, I think you can. If you want to send off a PCR, fine, but I think you can usually use these numbers as a relatively good guide to say what post-test probability is, especially in the context of multiple other viral infections. This costs similar to PCR. I think there are some issues now in Canada around getting the cartridges or validating the cartridges. Again, they were through a big federal purchase. The turnaround's 15 to 30 minutes. It does require a little bit of expertise. So you have to do the swab, open the cartridge, mix the cartridge, and then put it in the machine. There are some tricky lab licensing issues, especially if this is being used in a center where there is a lab. There may be the need for lab licensing. And then there's some validation issues. So if this gets moved, the calibration may change. It's probably not clinically significant, but again, from a lab QI standpoint, you have to kind of validate again. And so, the implementation may be a bit trickier in some contexts, but they've been really well used in many contexts across the country, and even in some of the smaller and rural hospitals have been a real success in terms of being able to do more rapid point of care testing with fairly reliable results. Finally, we have PCR. This is the gold standard. Everyone's got variable turnaround times based on where that PCR test goes, their locations, their lab capacity, their turnaround times, the transport. Their variable costs, good, high efficient homebrew labs can get it down to $20 to $30 a test. But when you're starting to use commercial assays, you're going to $100 to $150 a test. So, again, especially in a health resource strap system, you want to make sure that you're using these in appropriate populations. You can pick up very early cases, which is great. So the people that are that day one of symptom onset, should, if they have virus that's causing symptoms, they should test positive on PCR. So again, for that high-risk patient post-exposure that you're thinking about therapy that's symptomatic, maybe getting them to a PCR. The nice thing about most PCRs, again, across the country too, have been that they're healthcare administered. So some of the validation issues with kind of a self-administered test and technique are also limited, although there are some places doing self-collected PCR. And then finally, you want to make sure that you're knowing what your pretest probability is. And the one downside of molecular testing, PCR testing, is that people can shed virus well after they're in the infectious period, weeks and months. There's a great NBA study where in 2020, when they kind of went back into the NBA bubble, there were some of those players that were really shedding for weeks to months and playing at a high level. And, they made that bubble in very tight quadrants that weren't infectious. But, again, if you're swabbing someone asymptomatically and you get a positive result, you really want to make sure that you're describing a result that's COVID, because the likelihood is that it's probably an old COVID infection, not a new COVID infection. That being said, if someone comes in with fever, cough, shortness of breath, and has a positive PCR, and again, similarly, you can think about COVID, although we have seen COVID influenza, COVID RSV infections. So we have to just, again, keep what we think the appropriate clinical context is in mind. Okay, so moving on from testing, really talking about risk stratification of that patient coming into the ED of those diagnosed with COVID-19. So either they come in with a diagnosis or you're making the diagnosis for that person, what to do in terms of next steps. Again, we'll talk about treatment later, but in the next session, but kind of just more of a practical model in this sense. So, why test that person in ED? So you have a symptomatic person sitting there in the emergency room, you're thinking about doing a test, what are the types of things that run through your head? Well, number one, I think the most important is, especially if they're a high risk outpatient or, they're being admitted to hospital, is that having a positive test opens up therapeutic options that may mitigate the disease. And so you want to know exactly what they have to go through those therapeutic options in those patients. Patients may live in high-risk settings, so there may be some benefit even for people with mild infections that may not be appropriate for therapy. If they live in a shelter, live in a high-risk Indigenous community, live in a long-term care facility or a congregate care facility, even if they're mild, you may want to still make sure they know they have COVID so that the appropriate management can be done, even if you are sending them out, and isolation can be appropriate to mitigate spread. Obviously, if it's affecting medical management, not only in the acute COVID spectrum, but, we see these early complications from COVID like thromboses, myocarditis. And so again, kind of knowing the trigger for these may help with the medical management, what anticoagulant to use, but also long-term management, that it was a provoked PE. And so, how long to anticoagulate for. For non-respiratory complications, again, in that similar ballpark. And then finally, clinician discretion, individual reasoning, if you think that it's going to benefit this patient in that context. Again, with any test, you want to consider your pre-test. So are these people with symptoms compatible? What's your post-test probability? So, this person with diarrhea that I did a COVID test on that's positive, but has a history of ulcerative colitis, is that worsening diarrhea the COVID or the worsening of the ulcerative colitis? So you just, again, want to make sure that you understand the value of a positive test in the context of what's going on. And especially if you're using PCR testing, you want to ensure appropriate follow-up and reporting. And that's an important piece. We unfortunately do have people sent into congregate settings with a positive PCR that aren't reported for a day or two and unfortunately lead to transmission. And so we really, again, have to have a robust system if you're doing a PCR that someone needs to report it immediately if it is positive and it affects, the people around that individual. And so, what tests to do, depending on what setting you're in. I have a high-risk patient that is eligible for treatment. You really have three options. One is consider PCR with follow-up. You won't get that information at that moment for that patient, but as long as you can get back to them within a day, most treatments, again, 5-7 days to initiate treatment. So, there's still a benefit there. Secondly, rapid molecular tests. So, based on that data, I think I showed from Calgary, if you do a rapid molecular test, it's negative, I think, and your pretest probability was moderate, you probably can rule out. If it was really, really high, i.e. they've been exposed or something like that, then you may want to do your PCR on top. But I think you could probably go with a rapid molecular test to make a decision. And then, if you don't have access to that and you have rapid antigen tests, do the RAT, do it properly, throat nares, make sure you have the highest yield result. And if you have a positive, great, you can initiate therapy on that. But I would still make sure that people still get a molecular test as a backup for those people, just to make sure, again, that you still validate in 8 to 12 hours or 24 hours that they don't or do have COVID if it affects their therapeutic management. So, this is I'll throw in a case here. So you have a 70-year-old male with a positive COVID test with shortness of breath, 3 days onset, type 2 diabetes, obesity, hypertension, and asthma. on Symbicort, metformin, semaglutide, ramipril, rosuvastatin. He wants to be observed. He says, look, I have COVID, I'm high risk. I want to be admitted to the hospital for observation. He's had 4 vaccines, including his bivalent vaccine a month ago. And his exam shows a pretty normal exam, chest clear, chest x-ray normal, SATs of 96% on room air. And so, you based on the clinical judgment and healthcare capacity, have to make a decision on whether or not to admit this individual or send them home with follow-up. That's an important, I think we see these cases of people that may be worried about their own or even physicians referring patients that are worried about their own patients because of their underlying history and wanting kind of more observed COVID-19 therapy in that context. So, I will caveat this, who is going to be at the highest risk of deterioration? So number one is age. We know that, this is Ontario data from, I think about a month ago, looking at COVID-19 hospitalizations, breakthrough hospitalizations in vaccinated individuals. And you can see the age spectrum there, right? So, yes, that 80 to 90-year-old patient with 5 doses of vaccines may be much more protected than they have no vaccines, but there is still a not insignificant risk of them being hospitalized with that COVID-19 episode. Now, it may not be hypoxia, it may be diarrhea, it may be their underlying medical conditions that get exacerbated, but there is a risk of breakthrough hospitalization in the group. That 18-year-old that's had 4 doses of vaccine that has mild asthma, the odds of them being hospitalized is probably lower than not. So, when we're talking about this 70-year-old, 4 vaccine doses, so 2 or more booster doses, we're talking at about, a 1 in 100,000 person days risk of hospitalization. You have to take that in the context of is it worth it to use healthcare capacity for that person, especially if they're clinically well, or observe and consider therapeutics as a strategy to keep away from hospital in that sense. This is a nice breakthrough hospitalization study from the United Kingdom that actually goes to about April of 2022 and looks at high-risk medical conditions. Again, this is the rate ratio compared to an average population. And we see age, again, as the big risk factor, 80 being the highest, and then decades of life less than that. These are all breakthrough cases, so people that have had vaccinations. We see, in terms of medical conditions on the top right, organ transplants at the highest, bone marrow and immunosuppressants higher, neurologic disease, sickle cell disease, chronic kidney disease, cancers and cirrhosis, chemo being on the high end. And then things like asthma, even though have a little bit of a higher risk, are on the lower end of the spectrum. So again, this may be a nice tool to say, what do you think that person in front of you? So I have a 70-year-old, their adjusted rate ratio is about 2. Again, this may not be perfect because some of this incorporates health conditions. They have diabetes type 2, a slightly higher risk, coronary artery disease, slightly higher risk, asthma, slightly higher risk, obesity, I think is on here as well. But, again, you get a sense that they're probably at, the rate ratio is higher, but their absolute risk might be relatively low. And we have interventions to kind of help with preventing hospitalization in that sense. And I will say, this is just as an example. We'll talk about therapeutics in the next session. This is a study that was published by my colleagues in Toronto who do solid organ transplant. And even in the highest risk population, so if we look at that breakthrough chart, the highest risk were solid organ transplants. This is a study that was done of their solid organ transplants that were offered remdesivir. This is during the BA2 wave. And essentially one of them ended up in hospital if they got early remdesivir out of 86 patients. And so really talks to the power of offering early therapeutics to high-risk patients as a mitigation strategy. So that patient who wants to be admitted or you're worried about, think not necessarily about admitting to the hospital if they don't have clinical reasons to be in hospital, but really think seriously about therapeutics in that patient if it's indicated. Other things to consider, again, with that positive COVID diagnosis, that patient that's coming in feeling unwell may not have hypoxia. Make sure, especially ruling out post-COVID complications. I'll talk in the next session, I think, about things like ischemic disease and VTE as a complication. Is this COVID? So, is this person presenting short of breath because of the COVID? Particularly with PCR, yes, in a person that has compatible symptoms, you could be it. But if it's someone that's acutely short of breath and has a PCR that's positive, that it doesn't have any other symptoms, you still want to work up things like congestive heart failure, like COPD exacerbations, et cetera. And so really just making sure that you don't exclude the diagnosis just because of a positive swab. Where is this person going after? And again, that discussion about can they isolate safely if they're from a congregate setting? Is there anything that I need to do to make sure that that person's going in safely? Or again, if that person lives in a very high risk congregate setting, do you want to make sure, do they have the appropriate resources to deal with that patient going home overnight to wait for the results? And then again, do they have access to therapeutics if indicated? So how do you make sure that, especially if you're waiting for tests, that they can bridge the gap to therapeutics, or can you get someone to get therapeutics for them in that visit right there and then at the bedside? And so again, there's not really a slam dunk. If you look at things like Curve 65, they validate okay for COVID. There really isn't a lot of validation in the post-Omicron, post-vaccine era. But, again, just common sense, use your history and physical to determine admission status. So don't necessarily go based on risk, but go based on symptoms and the typical things that require people to be hospitalized for. Be aware that, it may be old COVID and another diagnosis. And so make sure you don't close your diagnostic window with a COVID test. Hypoxia is important. So if they're hypoxic, that is an indication, obviously, for admission. But it also opens up a new cascade of treatments, not only just antivirals, but anti-inflammatories. And then again, if you're thinking this person's high risk, fits the criteria that you would consider a therapeutic, make sure that they have an appropriate plan for a therapeutic so that you're not just sending them out into the world to figure it out. You can use that opportunity to start people on it to make sure they aren't hospitalized. The last thing I'll talk about, I think, is home oximetry. And so this was something that a lot of people had interest in at the beginning of the pandemic, about people having a home oximeter, and being sent home. This was, again, a pragmatic a study that was done kind of in the pre-Omicron, pre-vaccine window, so at a higher risk of hospitalization in the general population. And so this was a New England study that they randomized people 1-to-1 to oximeter versus just standard monitoring and follow-up and ending up in hospital. And interestingly, they saw no difference in death or hospitalization from day 30. They actually looked at anxiety scores and actually saw no difference in anxiety scores as well. And that's interesting, because I would hope that positive feedback from having an oximeter, would reduce anxiety, but they didn't actually see that. And so, I don't think, based on some of this data, is it's reasonable to tell everyone to go home with the oximeter and check. But, could you stratify this a bit more? This was kind of a standard population. Could you standardize this to, people with very rural settings where coming back to the hospital may not be easy, and you want to make sure they come back appropriately? People that are single, that don't have supports, where they may be the one that has to call 911. So it might be a tool for them. And then finally, people with significant underlying lung disease where their hypoxia may be borderline, you may want to make sure that this could be a strategy to help. But it's interesting that it doesn't, in a general population, especially in some of them that are at high risk of hospitalization, there were hospitalizations and deaths in this cohort, that early monitoring with hypoxia didn't really change things. So it would be interesting to see if with newer therapies this would still hold the same, but I would suspect you need a fairly large sample size to show any benefits here. And with that, I think we'll switch to Q&A. And I think this is next session too here. Oh.
Yeah, so that was fantastic. I actually really enjoyed that, Zain. You're talking like an emergency physician. You're talking about using common sense, understanding what tests can do and can't do, keep an open mind. COVID doesn't protect you against other diseases. And just because you have another disease doesn't mean that COVID hasn't been a precipitant to your visit. So that was very refreshing. So we have a bunch of questions. some of them are kind of segues for next week when we're going to be talking about therapeutics. But just to not get you into a deep conversation, but Raghu Venugopal sent a really good question, which is there have been all these vaccinated and reasonably healthy people that have suggested that Paxlovid isn't that useful, but there was one trial that said all comers did benefit. Is there a very short answer to what's the deal with Paxlovid?
Yeah, I mean, going back to the theme of common sense, patients who are at higher risk are going to benefit more from Paxlovid, right? Paxlovid's hard endpoint is hospitalization. So if you're an 18-year-old with a low risk of hospitalization, yes, you might make it even lower with Paxlovid, but if your risk of hospitalization is 0.1% and your risk of hospitalization post-Paxlovid is 0.01%, your number to need to treat is like 1,000 to get that patient. And even then, it might be the fluke more than anything else. The 70-year-old diabetic, hypertensive, who has 4 doses of vaccine, that's obese and has COPD, we have Ontario data, for example, when we were using a bit more of a rigid criteria that showed a number needed to treat of about 60 of immunocompromised, those over 70, those under 70 with under-vaccinated status and a single medical condition or over 60 and under-vaccinated. So, I think it guided based on where we think risk is, some of the stuff that I talked about today about who we think is highest risk of hospitalization. People are getting Paxlovid for preventing kind of post-acute COVID syndrome. People are getting Paxlovid to see if they can clear faster. Right now the data is not clear whether or not this is actually a real phenomenon or just something we find in registry studies. There was a large randomized controlled trial actually put on by Pfizer called EPIC-SR that looked at symptom-free, it was a weird endpoint, but symptom-free, time to being symptom-free for 4 days. And there was no difference between the group that was, and these were low-risk patients, so vaccinated and lower-risk unvaccinated patients, and they saw no difference. They actually aborted the study and have not published the results. So, all to say that it's not clear whether or not low-risk people would actually benefit more, but double down on the high-risk people because they will benefit in that sense.
Can I add to that, Zain? We do know from other viral and actually bacterial treatment that the earlier you treat, the better, and the later you treat, the less impact you're going to have on outcome. You did say that treatment up to 7 days has been shown to be beneficial. Is it still the earlier the better? I mean, is there ever a case where you might empirically treat someone where the results are equivocal just because you think I can't, we give people, ceftriaxone when they come in with a headache and a fever, even though we know that it's likely viral. We're just hedging our bets.
No, it's a good question. So, again, Paxlovid was trialed in 5 days, remdesivir in 7 days. I would say, look, the test results come back relatively quick. There was if you look at the EPIC-HR, which was the registration trial for Paxlovid in unvaccinated people, there was an improvement with every day closer to symptom onset that you got the dose in. It was a 90% reduction altogether, but it was, again, the tail of 5 days did worse than 4 days, that did worse than 3 days, than 2 days, than 1 day. So, I think it's still, given the drug, given the interactions, you want to make sure you're prescribing it appropriately to that patient. Given the access, I think is better in many settings, that as long as you have a plan for that patient to get it if they have a positive test, rather than having it on spec for symptoms, especially with all the other respiratory viruses out there. But if it is a person, for example, that is not going to be able to access healthcare for the next foreseeable future or 2 hours away, sending them with a prescription for it may not be the most unreasonable thing, because again, it's going to be more of a hassle when that positive test comes back. So, again, use your clinical discretion in that sense.
Excellent. So the next question, I think you both answered with your slides, but because we're having these conversations with our patients so often, is there a one-liner on, a 5-liner on what's the real benefit of vaccination?
Okay, first,
you got a week. You need a week to answer this, but I'll give you 5 seconds.
Sure. So I can give you my and my answer is going to be purely anecdotal. Zain is going to give you probably the more evidence-based answer. I have not had a vaccinated COVID patient that has been significantly unwell, certainly since this started. Like I've had lots of unvaccinated patients who have ended up in the unit or have ended up on high flow or BiPAP. But I will say that certainly anecdotally, my experience has been that if you're vaccinated, you are relatively protected against severe disease. But I think that's the caveat, is that it's severe disease. You can still get COVID, but you tend not to be as sick.
Yeah, and your slide with those gray bars were pretty dramatic. Sorry, go ahead, Zain.
Yeah, no, I completely agree with Alim. I mean, again, we have now data about severe disease. I have seen some severe cases, but they're immunocompromised, which is the big theme where vaccine responses may not be adequate. But absolutely, I mean, we don't see a lot of people needing tocilizumab and baricitinib and kind of the high flow and all that crap anymore. It really does seem to be very, even the people that need to be admitted are here for a little bit of dex and settle down very quickly. And then the other part I would say is there is actually data coming out now with some of the treatment trials that are being done in the United States that actually duration of symptoms seems to be smaller with people that have been fully vaccinated appropriately as compared to not. And that's interesting because again, even for influenza vaccine, I think a lot of people take the influenza vaccine for the same reason, maybe for community protection, but that they don't get sick or they don't have to spend as many days off work when they get influenza, if they get influenza. And so there are personal benefits in that sense. There are benefits obviously for the highest risk people to not end up in hospital. There's still obviously a lot of stuff around, if you've had three COVID shots and an infection, are you considered fully vaccinated? And that really is I think the struggle of the next few months and years to kind of figure this out. But there's still benefits from vaccine. I don't think that's negligible in that sense.
Fantastic. Another really interesting question from Tom, and I know there's a lot of anecdotal stuff going on. Which is worse at the moment, Omicron or influenza? What are the mortality? How do the mortality rates compare? If you had to choose an infection, which would you choose?
Yeah, it's interesting. I think over the last few years, they're like, oh, it's just the flu. It's just the flu. And I think with this horrible flu season that just kind of blew through, we forgot how bad the flu actually was, right? Like it can make people sick. And I remember being on call and seeing some relatively healthy young people being admitted for bad influenza and just forgetting that I saw this in 2019 and 2018. It was just kind of out of sight, out of mind. I will say, like, I can throw up a slide here, but this is just some data from Public Health Ontario looking at case fatality rates as the pandemic has progressed, basically. So case fatality rates are messy in the context of what Alim talked about, people that are actually doing PCR tests. So there is a skew. They're probably much, much more skewed down, especially in this area where we aren't doing PCRs on people to make the diagnosis. But you see that over every wave of the pandemic, case fatality rates have come down for COVID. And again, an 80-year-old in wave 7 with even all the biases, so probably, again, even much less than this, faces a 1% case fatality rate from COVID-19 when they faced a 35+% case fatality rate at the beginning of the pandemic. So, I think we are seeing this starting to become less virulent than influenza. The problem is that, we are seeing most people being infected once a year, maybe a little bit more than that. Omicron, it's not clear, whereas influenza, the infection per, cycle per year is actually not the entire population. It's much less. So, on a population standpoint, that still probably means a higher burden of illness, a higher burden of hospitalization, and a higher burden of death in the context where we have a short window of influenza, which affects 20 to 30% of the population, whereas COVID is continually infecting people and a year and a half between infections in that sense.
Excellent. We've just got time for one more, and I'm going to get each of you to answer it in turn. The issue of COVID-related myocarditis in young, healthy people, because we're talking about treatment, we're talking about investigation, sorry, not treatment. Do you care? So we have protocols that say everyone needs to have 2 troponins, and I let Alim go first. From your emerge perspective, I have a 20-year-old guy. He's probably had COVID, lives in a house where all the other students have had COVID, and he's got a bit of chest pain. He looks fine. His sats are fine. His heart rate is 65. Are you going to work this guy up for myocarditis, and what discharge instructions are you going to have him? And that, Alim, when you've done it, I'll get Zain to do it, and then we'll wrap up.
Sure. So where I think that there was a high pretest probability that the patient had COVID, I am testing for myocarditis, but I won't do 2 sets of tropes. I'll do a single set of tropes and a point of care ultrasound. Really what I'm looking for is that do they have good wall motion? Do they have a pericardial effusion? I think if their tropes are negative and they look stable, I'm actually discharging most of them with the usual follow-up instructions. If your symptoms get worse, particularly increasing shortness of breath or worsening chest pain, come back. I've had a couple of cases of post-COVID myocarditis. They've been very self-limited. They've been in hospital for like a day, maybe 2, and then they're discharged after a formal echo. If their tropes are positive, I am tending to refer them, only because I think if their tropes are positive, they probably do deserve some level of monitoring. But in almost all cases, they've been discharged in a day or 2 once their tropes peak and start to come down, and they have a normal echo. That's been my approach so far.
Yeah, good answer. Zain, you're the guy who sees them when they're in patients. Oh, you're muted.
I'm on mute. Yeah. So I would say, totally with Alim's approach. I would say it is a uncommon but well described post-COVID phenomenon. And so, I think in that context, for the number of people presenting for the that actually have myocarditis is probably low. The number that would be missed on a single troponin, normal ECG, normal POCUS, probably is low in that sense. So I think you can use your discretion, but the likelihood is if they have a normal trope, normal ECG, normal POCUS, you're probably not going to get anything more with further investigations in that sense. Given that if they have myocarditis, their trope probably should be up when they show up, right? Like they're not an MI where ischemia is just happening. It's cardiac inflammation that brought people in that sense.
But we saw viral myocarditis before COVID.
100%, and they would have tropes, and they would have ECG changes, and EFs of 10%, right? Yeah.
And I think the key is, I think this is in younger patients where ACS is not on the list, right? Where it is like we're not looking for ACS, we are looking specifically for myocarditis. It's an inflammatory process. I would expect their troponins to be elevated on the first go around, not I don't think, because we're not looking at a thrombotic or an embolic event. We're looking at they've got inflammation of their myocardium, right? So their tropes should be up already.
Excellent. I can't think of 2 better speakers that we could have had for this. As everyone can imagine, we needed the context of COVID. We couldn't dive straight into treatment, so we didn't have time to cover them both in one single webinar. So the phase 2 of the COVID webinar will be in 2 weeks. Lenora Saxinger will be here, and Jane will be back to talk specifically about COVID treatment. The learning objectives are as follows. I'd like you to all register. I'm definitely excited about it. Thank you both, Alim and Jane, for an incredibly informative talk. This is the great context that we're looking at all this, and I really love the common sense approach to it, which is something that as an emerge doc I can see the complete value in. I'd also like to thank everyone else who joined in today. The Scientific Planning Committee, of course, for their invaluable input, the CAPE staff team that have been really hard at work behind the scenes, Jeff, our IT support guy, who, as usual, has just done a sterling job. The session's been accredited by the College of Family Physicians of Canada and the Royal College. So please don't forget to complete your evaluation form so you can claim your credits. Everyone will get a certificate of attendance mailed out to them together with the evaluation link. Please give your evaluation. We want to keep improving these as much as we can. And we have a very interesting lineup of on-demand educational webinars planned over the next few months. So please keep an eye open for these, and please give us as much feedback as you can. Thank you very much for coming in. And with that, we are at exactly 3 o'clock Halifax time, 2 o'clock Ontario time. Thank you, everyone. Take care.